Tom Miller. Today we are talking about medical malpractice and medical liability, defensive medicine, causes, effects, and remedies, and they're really asking how defensive are physicians about medical liability. This is a long-standing item on the checklist of national health policy reforms, seeking a potential source of relief from costly and burdensome lawsuits for physicians and savings on the higher healthcare costs they're assumed to cause. Long litany of claims and counterclaims as to the effects of the medical liability system, not only the burden on physicians and those providing health care, but also on the flip side that a lot of people are injured, don't even bring lawsuits, let alone receive adequate compensation through other means. And too many of the people who sue and recover either were not harmed due to negligence or overcompensated. A litigation lottery that doesn't deter bad care, doesn't improve access to care, doesn't improve the overall system of healthcare delivery, and incurs unnecessary high transaction costs along the way. Aside from that, the medical liability system is working pretty well. So in the introduction to this form, indicates that, these traditional political and policy battles over medical malpractice reform usually follow some well-rehearsed scripts, highlights the relationship among the risk of lawsuits, defensive medicine, and physician supply responses, and damage cap remedies. And, why are we talking about this now? Well, if the medical liability issue isn't teed up now, it'll be teed up soon. It's kind of one of those recurring debates in the Washington policy circles. And if not soon, it'll be like the cicadas coming back, maybe a little bit more frequently than every 17 years. David's done some work on the frequency of the wave of insurance premium problems on that front. I used to use this slide for national health insurance, saying it would come up every 17 years, but I figured no good slide should be, not reused, repurposed for other reasons after our latest exercise, which made that a little less active than it previously was. What drives some of the discussion that comes up periodically? Well, one of the things that always can keep a good debate going is if you can find a budget score for it. And we saw this already in the ACA debate when the Congressional Budget Office re-examined its past extremely pessimistic or limited views as to the effects of liability reform with a cost estimate in 2009, which said that the direct costs weren't that great in terms of what doctors have to spend on insurance premium settlements, awards, administrative costs. That was about $35 billion back then, and that's not much in the larger world of healthcare expenditures. And then when you get into how much that would affect premiums with the liability reforms at that time, it only dropped about 10%. So we're still dealing with fairly trace elements. But then they found another area to expand in terms of budget savings, in terms of how liability reforms might reduce utilization of healthcare services. And that ties into the defensive medicine line of arguments, so that when you manipulate that, you get maybe more of a change in future annual health spending of about another 0.3%. And then in terms of the federal budget, which is all that really matters in terms of Washington, that could get you about $41 billion over 10 years for the various federal programs, and maybe squeeze out a little bit more on the tax side for increased revenue and taxable income. You got to about $54 billion over 10 years. If you don't think that's a lot of money, it's enough to drive proposals to say, well, we need some offsets in order to do other things. Now, there's some other elements to the issue. Let me get the other regenerative factors. Basically, the folks know how to assemble into skins and shirts, and so you get the rival gangs in the legal hood reassemble periodically to push their own particular causes. And also the idea that perhaps we could make a little bit of a bait and switch. You've got asymmetrical risk perceptions as to whether this is a big problem or a small problem, so might be able to trade off saying, oh, we'll give you that since we don't think it was worth very much in return for you agreeing to some other type of reforms. And David may have a few things to say about that in a few moments. I think the better way to think of it, I've been watching too much Homeland lately, is that we've got three different experts on this, and they have respective roles. David Hyman has done extensive empirical work. I mean, if you don't think you can torture data, you should talk to David and his friends. So it's the equivalent of empirical data waterboarding. I mean, they are confessing to everything by the time he's through, although more in one direction than the other, but that's what good interrogation techniques are all about. Now, Bapu Jena, on the other hand, is looking at the emotional toll on the victims. I mean, these doctors are subjects of legal terrorism. And whether or not the threats are real or not, they believe it is, and therefore that may affect their behavior in that regard. We have Mike Morrissey from Texas A&M, who is what I call our captologist. He's, how can we get under the cap in terms of spending with damage caps? Mike's been here before, written on that in field as well, as one of the remedies, which is not the end-all and be-all, but he can talk to that in addition to that. So with that, let me give a couple of short introductions. We'll start off with, I'll introduce our speakers separately. David Hyman is the H. Ross and Helen Workman Chair in Law and a Professor of Medicine at the University of Illinois, where he directs the Epstein Program in Health Law and Policy, although he's this fall teaching some classes at Georgetown University as a visiting professor. He focuses his research and writing on the regulation and financing of health care. He's also an adjunct scholar at AEI. Those of you with longer memories will recall that David was also a one-time special counsel of the Federal Trade Commission when they were dealing with healthcare antitrust, was principal author and project leader for the first joint report ever issued by the FTC and Justice Department called Improving Healthcare, A Dose of Competition. He's also the author of Medicare Meets Mephistopheles in 2006. That was selected by the U.S. Chamber of Commerce and the National Chamber Foundation as one of the 10 top books of 2007 and selected by me as the funniest health policy book of the last decade and publishes quite widely, as he'll tell you in many of his footnotes to his articles. We kid because we love. At that point, I better stop and let David get into some heavy weeds, but you're going to find some smoke coming out of it that makes sense.
Should I get the... So I'm appreciative of the we kid because we love, or otherwise I draw a different conclusion. As the representative of empirical waterboarding, that's Bapu's slides, not mine.
They must have put in the order. Skip through them, and you probably must be at the back end.
Well, let's hope, or this is going to be a very short presentation. There we go. At the outset, I should say nothing that I'm going to present should be viewed as detracting from the psychic and emotional cost that the malpractice system imposes on physicians. I teach in a medical school. I'm appointed in a medical school, and every year I give them lectures on medical malpractice, and one of the things I say to them is being sued for malpractice is the worst thing that will ever happen to you in your life, except for the loss of a spouse or a child. For physicians, these are intensely emotional attacks on their professional competence, and it's part of the reason why I think it's important to actually understand the system, figure out what it's doing and what it's not doing, and whether there are ways in which we can improve it. That said, I'm going to spend most of my time talking about work that we've done, along with a series of co-authors, and let me just give you a little bit of framing for what I'm going to say. We've had 3 major malpractice crises in the United States since the 1970s. You can see the years when they occurred. A malpractice crisis is not defined as an increase in malpractice. It's a sudden and dramatic increase in malpractice premiums, which is not necessarily the same thing and may not be the same thing at all. Along with some co-authors, Bernie Black at Northwestern, Charlie Silver at the University of Texas, and Myung-Ho Paek, who's at Hanyang University in Korea, we've done pretty extensive studies of what we call the third wave of malpractice and malpractice reform. And you can sort of see the numbers there, starting in basically the end of 1999, running through mid-2005, more or less. You can see 12 states enacted caps on non-economic damages, and a couple of states enacted either punitive damages caps, collateral source rule revisions, or amended the joint and several liability rule. To give you a sense of the temporal sequence, this is probably really hard to see in the back, but blue are the non-economic cap adoptions, and it starts in 95 and goes through 2008, and most of the action, not surprisingly, is sort of in 2001 through 2005. With most of the caps coming in 2003, including Texas, which we have spent a fair amount of time studying because there's publicly available data. More on that in a minute. If you look at the sort of geographic distribution of caps at the current time, what you see is really three different sets of states, what we call old cap states. Those are states that adopted caps in the 70s and early 80s. New cap states, which adopted caps in the 90s or early 2000s, and no cap states, states that basically have never adopted caps. And you can sort of see we have 12 new cap states. Those are the green states. 19 old cap states. Those are the sort of purplish red states. And 20 no cap states. And if you do the math, that's 51 because the District of Columbia counts as a state in all of these calculations. And Alaska and Hawaii, which don't appear on the map, are old cap states. I should note that if you adopted a cap during the period that we're looking at, even if the state Supreme Court subsequently struck it down, you'll be treated as a new cap state for purposes of our analysis. So Illinois, for example, which adopted a cap in 2005 and subsequently struck down by the Illinois Supreme Court in 2010, is colored green as a new cap state. Okay, just a sort of clarification. I should note also my home state of Illinois has enacted non-economic damage caps 3 times and struck them down by the Illinois Supreme Court 3 times as well. So we're 3 for 3. It's quite clear if we want to have caps. Well, we're going to need a different set of Supreme Court justices in order to get caps into effect in Illinois. Texas obviously had to get a constitutional amendment to get a cap in effect. So the scope of our work that I'm going to be talking about is we study the impact of the tort reforms that got enacted on claim frequency and payout per claim. You can think about that as being a component internal to the tort system. And then 2 external factors, physician supply, how do caps affect whether physicians move to your state, or the absence of caps encourage them to flee your state jurisdiction or at least avoid it. And then finally, defensive medicine, which Tom mentioned briefly. I suspect everybody in the room has some notion about what we mean by defensive medicine, and we can talk more about that as we go forward. You can think about studying defensive medicine in this context as seeing the extent to which enacting tort reform affects the level and trend of healthcare spending. The theory being if you restrict liability, there's less of an incentive to engage in liability preventing treatment decisions, i.e. defensive medicine. And we use a diverse set of data sources. We use nationwide data to study old cap versus new cap versus no cap states. We've also done state-specific studies of Texas and Illinois, which have been published, and we're working on Indiana. Eventually, we're going to run out of states, but I think my career will end before we go international, yes. All right, and we've got a bunch of publications, and you can find them all on ssrn.com, freely downloadable, including everything I'm going to show you today. Just a sort of lit review and acknowledgement of past work in this space, including by both of my co-panelists. One of the nice things about AEI is they can get great people to come. And so you've got a very impressive group of presenters here, and then they invited me too. Lots of studies of claim frequency and payout per claim and the effect of tort reform on it. Including by Jenna, that's this fellow right here, and he's on 2 of those. Physician supply, as you can see the authors, and defensive medicine, and somehow they posted the wrong set of slides because I added Morrissey's paper on basically on claim frequency and payout per claim and the impact. So anyway, I'm going to take away from Michael one of his comments that I didn't quote him or his work in this space. To summarize very briefly, a very extensive set of research, caps on non-economic damages have an effect. The magnitude of the effect depends a little bit on which cap you adopt. It also has an effect that's discernible on insurance premiums, but that can be a little bit harder to establish. The effect on physician supply is less impressive than lots of people think. There's some evidence indicating in rural areas and in certain specialties, enacting caps will encourage physicians to relocate to your state or at least to start their practice there. but the past research doesn't suggest that this is a huge way of attracting physicians. And then finally, defensive medicine. The early papers, Kessler and McClellan in particular, had pretty impressive numbers. Subsequent research, I think, has sort of moved the range of plausible defensive medicine that you will get rid of by enacting tort reform down. That doesn't mean that there isn't still defensive medicine going on. It just means tort reform may not be as effective a strategy of addressing it as people think. So that's basically my summary of the past work. Quick theory, what should tort reform do? Well, if it's working, it ought to reduce payout per claim and claim frequency. It ought to increase physician supply. If you lower the cost for practicing in a state, you ought to, at the margins, make a difference in physicians' willingness to be there. It's an interesting question how it might play out differently depending on the point in the life cycle of the physician's practice, right? It might be easier to get physicians who are starting their career or who are at the end of their career to defer retirement as opposed to mid-career physicians who have an established practice and saying to them you should pick up and move across state borders to get a lower insurance policy may turn out not to work as effectively. There's a more ambiguous theoretical effect on defensive medicine. There are reasons for thinking that defensive medicine is made up of two things, what it's called assurance practices, running more tests, and avoidance practices, not doing certain things. If you get rid of the liability risk, you'll probably decrease assurance behavior, but you may increase what would otherwise be avoidance behavior, so people's willingness to do more risky things. And so it's ultimately an empirical question, the overall effect. Quality, you can tell a sort of ambiguous theoretical story as well. If we think the system is deterring bad treatments, then if you get rid of liability risk, we may get more bad treatments. If, on the other hand, it's just causing people to do stupid stuff, then getting rid of stupid stuff could be an increase in quality. Additional complications are caps vary, right? States vary as to the caps they adopt, so grouping all caps together may muddy your estimates. And tort reforms are usually bundled, so disaggregating the impact of one tort reform from another can turn out to be a little difficult. So this is from a series of papers we did called The Receding Tide, and each of these lines is either a no cap, that's the blue line, a new cap, that's the red line, or an old cap, that's the green line, set of states. And the left side is basically claim frequency, and the right side is payout per claim. Actually, it's payout per physician here, just to sort of standardize it. And what do you see? Well, you see a couple of different things. The first thing you see is that since basically around 2001, there's been a downward trend in both the number of claims and the payout per claim in all states, in states that adopted reform and also in states that didn't adopt reform. And that's somewhat puzzling, right? It's easy to see why they might go down in states that adopted reform in the 2000 period. It's less obvious why they would be going down everywhere else, but they are going down. The second thing you see is that prior to the reform period, and that's these vertical lines here that you can't see on the television screen, but they're vertical lines, red lines around 2002 through 2005. That's when the states, the new cap states, adopted reform. Prior to that period, the new cap states look like the no cap states. And then after that period, the results for both figures for the new cap states drop dramatically and converge with the old cap states. So caps have an effect. They have an effect on both claim volume and on payout per claim. But that's also superimposed on some larger pre-existing trends that you also need to keep track of. So anybody who says caps don't have an effect, I think the research of this and other work that others have done suggests that that's just implausible on its face. Caps do have an impact. They have an impact on factors internal to the tort system, the precise magnitude of which varies from state to state. What about in Texas? Well, these are Texas-specific results rather than nationwide results. Texas adopts a cap with the vertical red line, and the two lines are for the number of claims per population, and it's somehow been truncated off, but it's basically payout per capita. During the pre-reform period, both of those are basically reasonably stable. After you enact tort reform, both of them more or less fall off a cliff. Okay, now we've picked the scale to somewhat make that point clearer, but we're talking about absolute increases that are pretty dramatic. A 60% drop in claims, a 45% drop in payout per claim, a combined effect of 75%. That is basically the money flowing through the medical malpractice system drops by 3/4 as a result of enacting a reasonably strict cap on non-economic damages. Let me now switch to talk about some Illinois data. This is a forthcoming paper, and this should maybe make you feel at least a little bit better about the rationality of the tort system. On the x-axis, we have level of injury severity on a 9-point NAI, National Association of Insurance Commissioners scale. Blue is mean payout, red is median payout. So the good news is the more severely injured you are, the larger the amount of money the tort system pays you. So that's some ways reassuring. It's not completely irrational. It doesn't tell you anything about whether you are undercompensated or overcompensated, but there's at least some level of vertical consistency. The other thing you observe, which is kind of interesting, is what we call a death discount. The next to last lines are for permanent grave injury. The last lines are for death. So being permanently and gravely injured results in a much higher payout than death. That makes sense because damages are tied to economic and non-economic losses, and lifetime medical treatment can result in a sizable amount of economic losses, whereas death, just you basically don't have that long-term trend. So some evidence of intrasystem rationality. We're also not talking about staggering amounts of money here, right? So the top of the scale is at $1 million. Death is in the neighborhood of about $560,000. That's not a lot of money for a death from medical malpractice. It's certainly, you do see certainly cases involving tens of millions of dollars. Those tend to be bad baby cases with horrendous injuries that require lifetime medical treatment. If you look at time trends, blue is the mean payout, red is the median payout, green is the ratio between the two. Let's just ignore the ratio and look at this. And what you see, which is somewhat interesting, is obviously a steady upward trend in both the mean and median payout over time. It turns out that's pretty much artificial. And why is that? It's because the small claims are going away. And then when we average what's left over, the mean and median steadily climb. But it isn't because the system's becoming more generous over time. It's because the smaller claims are just disappearing. And I'll show you some regression results that make that clear. And they're right here. The top row are the year trend on log payout. And you can see various adjustments. Basically, the first column shows there's a 7% per year increase in mean payout over the 30 years of data that we have. But the last two columns show that if you control for specialty and severity, and you only focus on cases where the payout is more than $100,000, it goes away completely. Okay, so mostly what's going on is the cases with less than $100,000 are going away, and then we have a big trend as a result of that. What about the supply of physicians? Let's now just switch gears and talk about that. This is Texas-specific data. The red line shows where Texas adopted caps. These are what are called DPC physicians, or direct patient care physicians, licensed in the state. This is data from the Texas State Department of Health Services. And we've got DPC physicians in the red line that's on the top, and the blue line is physicians per capita. And basically during the pre-reform period, you see that Texas is growing and more physicians are coming to the state. And in the post-reform period, you basically see the trends that were occurring pre-reform pretty much continue. There's not a dramatic upswing in the number of physicians, either in absolute numbers or in controlling for population. In fact, if you control for population, it flattens out a little bit. Why is it that there were wide reports that there were increases in the number of physicians? It's because people were focusing on the number of applications, right? And if you want to look at physicians, you have to look at both entry and exit and take account of population growth and pre-existing trends. That's the only way in which you can figure out whether something like tort reform is really making a difference. And we don't really see it here. We also don't see it when we look nationwide. This is another new cap versus no cap comparison. We just do the ratio. So the blue line is new cap over no cap, and it's just a ratio. And we've got the same vertical lines. If tort reform has an effect on physician supply, the numbers ought to sort of swing upwards in the post-reform period. We don't really see much evidence of that. We also don't see it in rural counties. We actually see a decline when we focus on rural counties. And then these are some summary statistics, which nobody can read, but I will tell you the short version, which is by specialty, and we use Jenna's top 8 high-risk specialties to do this analysis. We really don't see any effect at all on physician supply in the expected direction, except for plastic surgery. If you want more plastic surgeons, tort reform, interestingly, appears to be one way of doing it. But I don't think that was the priority for the people who were pushing tort reform, right? They're thinking about neurosurgeons and obstetricians, and we just don't find any evidence of that. I'll skip that in the interest of time. I'll skip the DID results. And we did fancy, complicated regressions, which basically found a whole lot of nothing. Okay, we have a very precisely specified no result. What about defensive medicine? Well, this is another sort of no cap versus new cap comparison, old cap and new cap versus no cap comparison with Medicare Part A on the left side and Medicare Part B on the right side. And it's the same sort of framework. The vertical lines are the period during which the new cap states adopted tort reform. And we don't see any evidence of much of an impact on Part A. Part B, we do see an impact. Tort reform appears to result in somewhat increased healthcare spending. Not the expected decrease, but an increase. And if you think that avoidance behavior dominates assurance behavior, then that makes a certain amount of sense. We're in the process of doing a more detailed study trying to nail down specific types of treatments and whether they increase in the post-reform period. And I'll skip the DID. So let me summarize, and then I'll just briefly mention some of the policy implications. So we find that caps result in less medical malpractice litigation. We find that everywhere we look. We find it in individual states. We find it nationwide. It results in fewer claims. It results in lower payouts per claim. And there's a very sizable drop in payout for a physician, and so we would expect that to play out in terms of lower malpractice premiums come the next malpractice crisis, and also less variance. We find evidence of higher healthcare costs, particularly in Part B, that is outpatient, and no effect on Part A. It doesn't seem to affect hospitalization rates. We don't see any effect on physician supply. There's some separate research that I haven't presented that looks at quality that Bernie Black has done with some co-authors, and we have the ongoing work that I talked about. Our preliminary results there suggest that enacting tort reform actually increases the frequency of what are PSIs, patient safety indicator problems. So somewhat disconcerting, right? The tort reform dramatically reduces malpractice claiming, doesn't seem to affect physician supply, appears to increase healthcare costs, and may increase quality problems. So as we've written in numerous articles, this is not a magic bullet. 30 states have adopted it. It's unlikely that the other 20 are going to go along anytime soon. So where do we go next? And my last slide is not here, but you have a copy. But I'm happy to talk about it and then scroll back to Bapu's slides while I'm doing it. It seems to me there are a couple of possibilities that we should be thinking about, right? One of them, and now I can't get his either, so let me turn it over to somebody else and work on this. Yeah. Oh, okay. So one possibility is to think about exploiting what Tom started off with, which is physicians obviously value caps highly. And so maybe the way to deal with the other 20 states is to offer to make a deal. I have an article in Health Affairs with Bill Sage that talks about this as a way of basically offering physicians something they want in exchange for something the rest of us should want, which is delivery side reform and more innovation on the delivery side. I think the politics of the 20 states that remain is such that it's going to be very difficult to think you're going to get caps, even if you want them, without doing something new or different. So I think making a deal might make some sense. Second, I think we should be exploring something that was used a while back and has been largely abandoned, which is to think about no fault. But no fault here limited to small claims, which have been pretty much completely squeezed out of the system. And so the politics of using no fault for things that are out of the system is very different than for things that are being handled by the existing system. I think these are people who are getting the shaft, and we ought to think about ways to try and deal with their problems. This is real underclaiming, people who used to be handled by the system and are no longer. Third, I think communication and resolution programs are an interesting idea. I don't think they're a magic bullet. But I think being honest with your patients is probably a pretty sensible strategy. The best evidence is that people sue not because they were treated wrongly in the sense of receiving negligent treatment, but because they're angry at how they were treated after something bad happened. They felt like they couldn't get straight answers. And so I think CRP programs have a lot of promise for dealing with that. The last thing, I went to the University of Chicago, and we like private contracts. So I think private contracts have some promise as a way of experimentation and trying to finesse the top-down solutions that people seem to like in Washington. Let's let individual providers offer whatever contracts on liability they want, along with all the other terms and conditions, and see where we can come up with a focal point that'll give patients a better solution than the liability system is right now. So let me stop there. Thank you for your attention.
All right, thank you very much, David. One of the points was that a receding tide first sinks the small boats of lawsuits and then works on some of the other ones in terms of taking the top off the yacht, I guess. Our next speaker is Bapu Jena. He's a principal consultant at Precision Health Economics and also an assistant professor of health policy and medicine at Harvard Medical School and an attending physician at Mass General Hospital, where he practices general inpatient medicine and teaches medical residents. He recently, he's been writing in this field for a while. The most recent article is in the British Medical Journal, I noticed, on physicians' spending and subsequent risk of malpractice claims, but has broader work in this field beyond that. Some years back, along with Tom Phillipson, he was a winner of the Eugene Garfield Award from Research America for the best paper in economics on the economic impact of medical research, and he's also a research fellow at the National Bureau of Economic Research.
Thank you. So I'll actually start with a medical joke that's not related to malpractice, see if you guys have heard it. So part of my research is to study what happens to patients when cardiologists attend national conferences, and we find that they actually do better, surprisingly. So how do you hide a dollar from an internist? Does anybody know? So how do you hide a dollar from an internist? How do you hide a dollar bill from an internist? Plain sight, or you put it underneath the bandage. They don't like to look underneath bandages. How do you hide a dollar bill from an orthopedic surgeon? Break it. Or you put it in a medical chart or a textbook, anything that confers kind of gaining knowledge, anything like that would have sufficed. How do you hide a dollar bill from a cardiologist?
You can't.
You can't hide a dollar bill from a cardiologist. So that has absolutely nothing to do with what I'm about to talk to you about today. But it's a good joke, I think. So I think David laid out very nicely, I think, what's the policy landscape that a lot of the medical malpractice scholars have been thinking about in this area. And as Tom mentioned, my background is I'm a physician and an economist. And so the way we approach this, the way my colleagues and I have been thinking about the issues around medical malpractice is really from the physician perspective. But we've tried to move past some of the smaller studies that look at why it is that individual physicians get sued and trying to paint a broader narrative kind of from the physician perspective. And that's what I'd like to share with you today. And I think it's a nice complement to what David talked about. And so my comments are titled Medical Malpractice and the Physician. And so what I'll do is, first, I can't actually read this, but I'll share with you two stories. We have worked with data from a very large professional liability insurer who was kind enough to share their malpractice claims histories on about 40,000 physicians that they insured over about a 10 to 15-year period starting in the mid-1990s. And these are just two vignettes from that malpractice insurer. I'll try to read them out loud here. The unknown aged male emergency room patient was seen by the insured. So these are just short vignettes for complaints of chest discomfort and had a choking sensation when swallowing.
Do you want to go walk over there? So I think you need to turn it on, but you can just walk.
Oh, that's perfect. The insured, so again, this is the physician, contacted the patient's primary physician and agreed to admit the patient for a suspected cardiac event. The patient expired the next morning at the hospital, and autopsy revealed a ruptured dissecting aortic aneurysm. So there are typos in here, but this is directly what we got from the insurer. And the outcome of this this claim is that it was settled before trial verdict. So this is a particular kind of condition that a lot of emergency medicine physicians will be very careful about and think carefully about. And that's when you come in with chest pain, do you think it's a heart attack? Do you think it's a clot in your lungs? No, it actually turns out to be that your aorta is dissecting. And it's something that the story has to be very specific, but you might miss it. And so not surprisingly in this case, this was settled before a trial verdict. Makes sense. This is probably would fall under what we would classically think of as being malpractice. The second story is this X-year-old male outpatient was referred to the insured. Again, this is a physician for complaints of chest pain. The insured advised the patient to go to the hospital for catheterization. The patient refused and scheduled an appointment at the hospital 2 days later. The patient died the day prior to the hospital catheterization. So the point here is if you read this story, you would think, wow, that's obviously extremely unfortunate, but where is the malpractice in this case? Not surprisingly, it was dismissed in trial, but it took between 3 to 4 years for that to occur. And during this period, as David mentioned, there's a tremendous amount of resource and anxiety that goes in, not only in the physician's part, but the family, colleagues, that goes into a trial like this. And so this is just to give you a sense of, when you hear doctors talk about malpractice, it's the number one thing that they talk about. In some sense, it's a privilege to be able to write in this area because there's always an appetite for this material when it comes to doctors. It's probably the number one thing that they care about in their career. And as David mentioned, it's probably the most challenging thing that a doctor will ever experience in their lifetime aside from loss of a family member. So why do physicians care about malpractice? So if you're an economist, you'd say, well, why do you care? You're essentially fully insured against it. Almost all the financial costs associated with being sued is insurable against. So why would it be that physicians would care about it? I would respond by saying most of you probably drive in this room, and you have, I'm sure, pretty generous car insurance, but yet nobody wants to get into a car accident because there's tremendous non-financial cost associated with being in a car accident. There's anxiety, there's time you have to take off from work, which would be a financial cost, but it's not a cost that's reimbursed by the insurer. And so that's just to give you a sense. Look, this is an issue that has consequences for physicians besides what the actual amounts are that are paid in a lawsuit or in defense. So from a lifetime perspective, turns out that malpractice is actually very, very salient to a physician. So if I were to ask you, actually, let me just take a poll of the audience. You guys can have a chance to take a look at the number. Let's say that you're in a high-risk specialty, which we can define as roughly the top half of specialties. What fraction of doctors do you think will be sued? So not make a malpractice payment, but just be sued by the end of their career. Let's say you retire around 65 or 70, and I'll ask you to raise your hands. Let's say 30%. Raise your hand if you think 30% of doctors will be sued by the end of their career if they work in a high-risk specialty. So we have one for 30%. Who says 50%, 70%, 100%? So a few said 100%. So it turns out it's 100%. So if you work in a high-risk specialty, the likelihood of you getting sued is basically 100% by the end of your career. How do we know?
You want to get it done early so you get it out of the way.
Exactly. That's been my personal approach to the issue. No, I only practice 4 to 6 weeks out of the year, so I'm actually I'm insured against malpractice because I don't practice often enough. So this is some data that we had the privilege to work with from this large liability insurer, And we had data on physicians from 1995 until, I think, 2006. And so we could follow physicians longitudinally over their careers. We knew when they had been sued, whether they had lost the case, what they had been sued for. We knew some demographics about the physicians as well. And what I've plotted here is essentially a lifetime risk of being sued. So again, if you're in a high-risk specialty, the likelihood of you being sued is about 100% by the end of your career. The likelihood of you making a payment, so losing a case by the end of your career, is about 70%. And numbers are still quite high for even the low-risk specialty. So if you're in a low-risk specialty, the likelihood that you're going to pay out by the end of your career is around 30%. So from a lifetime perspective, malpractice is extraordinarily salient to the individual physician. This is some data from the same paper. I apologize, it's very difficult to see from back there. But both of these figures were published in the New England Journal of Medicine in 2011. And what we did here was we used data from the same insurer to do a very simple descriptive statistic, and that is how likely are you to be sued if you're in a given specialty. You would think that that would actually be common knowledge, and a lot of people would know that, but it turns out that this kind of data had just not been had not been publicly available for a long time. And we were able to analyze this. Turns out if you're in neurosurgery, which is the top bar there, your likelihood of being sued is about 22% in a given year. For the typical physician, it's about 5 to 7%. And so if you're in internal medicine, it would be around that. And as you can see, there's a tremendous variation, not surprisingly, across specialties, especially such as obstetrics and gynecology, that we hear about quite often as being a high-risk specialty. Is certainly high risk, but is probably, can't see from here, but probably 5th or 6th down the row in terms of specialties. But it is very high risk. So this is a question for you all. What proportion of the average physician's career is spent with an open malpractice suit? So if you think about how many years a physician's in practice, what proportion of his or her career do you think is spent with an open malpractice suit? So let's get a raise of hands for the first one. A, is that say 1%? Mm-hmm. So who says 1% of your career is spent with an open malpractice suit? 5%? 10%? 18.5%? So this is a behavioral trick. Because 18.5%, I just put the 0.5 there to have you anchor in on the 18.5. Turns out it's actually 11%. And where that, and this is for the typical physician, where that number comes from is basically how often physicians get sued and how long it takes for a suit to be resolved. So the typical suit that doesn't go to, isn't heard in court will be about 2 to 3 years. If it goes to court, 4 to 5 years. And so you kind of multiply those two things roughly, and that gives you a sense of what duration over a physician's career do they spend within a kind of a malpractice suit that's looming over their head. Turns out that if you're in neurosurgery, not surprisingly, you're highly likely to get sued, but also the suits tend to last a little bit longer. And so these physicians spend a third of their career on average with a suit. So the basic point here is again, talking about what David said, is we have this paradox where economists and health policy researchers, health services researchers estimate the magnitude of defensive medicine and estimate the cost of the medical malpractice liability system, and yet this continues to be a perennial issue, and here's why it is. Because doctors care about it, and they care about it because it's salient to them. It's not something that's coming out of thin air that they have perceptions about. It's actually a real thing that they face. That's my view, at least. So this is a graph where that statistic comes from. This basically shows, this is from Health Affairs, where we estimated the fraction of a physician's career that they spent with a suit. Neurosurgery is at the top. The typical physician is about 10 to 11%. So internal medicine is your primary care doctor. He or she would spend about 11% of his or her career with a suit.
Do you have any data on the distribution in terms of physicians who were sued several times in different specialties, and then change the average as opposed to distribution?
Yeah, so that is part of it. So for instance, in a high-risk specialty, you're going to be sued more often, and that will increase. That contributes to the greater proportion. Absolutely. So what about defensive medicine? And as David kind of outlined, when we think about defensive medicine, there's a very specific connotation or a very specific definition of what it means. It's essentially the ordering of tests and procedures that's motivated by malpractice concerns, motivated by malpractice liability, but that is not clinically beneficial to a patient. So for instance, if you were to find that a malpractice system induced doctors to do more age-appropriate colon cancer screening, we wouldn't want to call that defensive medicine. That's actually the deterrence effect. That's the appropriate effect of the malpractice system. And so defensive medicine really is intended to measure wasteful healthcare spending. And it's difficult to measure waste because it's difficult to measure value. And we look at things like mortality and complication rates as measures of clinical outcomes, but a lot of things affect mortality rates and clinical complication rates. So this right here is a figure that we produced in the Wall Street Journal a few years ago. And the basic crux of the article was the following. It seemed to my co-authors and I, Seth Seabury, who's at USC, and Amitabh Chandra, who's at the Kennedy School at Harvard, it seemed to us that there was this paradox between what doctors perceive about malpractice and what economists and other medical malpractice scholars think about the magnitude of the problem. And I'd be curious to hear David's thoughts afterwards, but I think it's a fair characterization to say, at least in my mind, that there is somewhat of a puzzle because in terms of healthcare spending, we think that malpractice, the liability system is maybe 2 to 5%, somewhere in that ballpark of overall healthcare spending. And yet 90% of physicians report practicing defensive medicine. They clearly get up in arms about it. So is it the case that these things can be fully explained by the same mechanism, or is there actually some sort of paradox? And at least to me, that's always a challenging question. And it really gets to the core of, I think, the core of David and others' work. And what the prior work has shown is what happens to healthcare spending when you change from one liability environment to another. So if you're looking at specific types of tort reforms, what happens as states adopt tort reforms? What happens to healthcare spending? So if you think about this curve, it's essentially the x-axis is a state's malpractice environment. The far right you can think of as being a high-risk environment. To the left, a lower-risk environment. And as you move up the red line, healthcare spending goes up. And so in environments which are very high risk, doctors are, let's say, practicing more assurance behavior, just to keep it simple. And if you're in a lower risk state, you would see less defensive healthcare spending. And what the current estimates tell us about this issue is what happens when you move from a high risk environment to a low risk environment. How much more healthcare spending can you reduce? How much healthcare spending can you reduce with these types of tort reforms? Those are what the estimates from the literature tell us. And they're extraordinarily useful because they tell us, well, these are the policies that many states would be considering, and here's what the effect, the anticipated effect of these tort reforms are. But that is a different question than saying, how much defensive medicine do doctors practice? It is a different question than how much defensive medicine do doctors practice. And what I mean by that is if you look at these low-risk, quote-unquote, states, what you will find in surveys is that in these states, 50 to 60% of doctors at least report practicing defensive medicine. And what that means is that it could very well be the case that the tort reforms that we have in place or that we're able to study, they do reduce healthcare spending in let's say, some studies, not all, but in some studies, they do reduce healthcare spending, but that kind of that second bar right there, which says true defensive medicine, that's the amount of medicine that's being done because doctors are worried about liability. Another way to put it would be that if you completely eliminated the malpractice system and didn't hold doctors accountable at all, which I don't think anybody would argue for, but if that were the case, then how much healthcare spending would you have? And that number, I think, would be considerably greater than what we estimate in the studies today. And the reason that's important, from my perspective, is that it helps us start to reconcile why it is that economists and others would argue that defensive healthcare spending is not a large component of overall healthcare spending, whereas doctors continue to raise this as a critical issue in their mind. The last thing I want to address is this question of whether or not defensive medicine even works. And what I mean by that is the following, is that the presumption of defensive medicine is that if you do more, you spend more, as a physician, you're less likely to get sued. Turns out that that actually has never really been studied. Because you could imagine, as David said earlier, that a physician gets sued because of his or her relationship with a patient, whether or not he or she communicates well with the patient, discloses errors, is apologetic, makes appropriate clinical remedies. You could imagine that those factors are what drive a patient's decision to sue, as opposed to what's kind of the overall level of utilization that the physician decided upon. And so it could be that defensive medicine may not even work. It may not even reduce liability. But as I said, that question has not been explored. So what we did, and this is something that Tom referred to in the last couple of slides, I'll just walk you through it, is we got data from Florida, which others have worked with it as well, and we linked information on physician practice patterns to whether or not they had been sued and paid a malpractice claim. So we profile physicians in terms of their practice patterns, their kind of their overall costs, trying to account as much as possible for the different types of patients that they see, the conditions that they treat, and then we look at whether or not higher spending physicians get sued less often. That is not necessarily the same thing as whether defensive medicine works, but in my view, it's the first step in that direction to answering that question. So the empirical question that we had was, do higher spending physicians get sued less often once you account for the different risks of their patients? And what we found is across 7 specialties, we looked at 7 specialties, in 6 of those 7 specialties, physicians in Florida with higher risk-adjusted spending were sued less often in the subsequent year. And the idea is, you spend more in this year, does that change kind of the milieu of your liability risk in that year? And what we found was there is a negative association. Even in family medicine, where we didn't find a statistically significant effect, it still points in the right direction, and that was one of the specialties where we had less data in. And so the summary of this table and the summary of this work, which was published in the British Medical Journal, was that higher spending doctors within a specialty are sued less often. One criticism, which would be very valid, would be that higher spending doctors, they are higher spending because they treat sicker patients. That could be true. If that were the case, then you would actually think that sicker patients would be at higher likelihood of risks, and so you might actually find a positive relationship. So that bias actually works in our direction. The other criticism you might make is that, well, you don't actually have good data on the socioeconomic status of patients. If doctors perceive lower SES patients to be at higher risk of malpractice, then they might spend more on them. But if it turns out that they are at lower risk of suing, which there is some evidence to suggest, then we might have this artificial negative relationship, which is not true. And the way we addressed that in the paper, and I don't have this in the slide here, was we not only looked at whether higher spending physicians get sued less often than lower spending physicians, but we also looked at the same physician over time. So we followed that physician in years when he or she spent more versus spent less. And what we find is that in years when that physician spends more, they're less likely to be subsequently sued than in years when they spend less. And so that analysis to me is more convincing. It addresses some of the concerns that one might have. We find the same thing, I'll note, in obstetrics. C-sections have often been regarded as a measure for defensive medicine. To be honest, I'm a physician, and it's not entirely clear to me where C-sections came from as a kind of good measure of defensive medicine, but the history is in the economics literature, and a number of people have used C-sections as a measure for defensive medicine. And what we find is that doctors, obstetricians more specifically, with higher rates of C-sections get sued less often. So again, this is kind of a clinical example of that broader association that I just outlined that points in the same direction. And the question then is, what's the interpretation? I mean, there's many interpretations. One is that we're picking up something else. We try to address that by looking at the same physician over time. The second could be that this is actually good medicine, good outcomes, that higher spending doctors actually have better outcomes and fewer adverse events, and that's why they get sued less often. There has actually been, I would venture to say, almost no work looking at the association between physician-level spending and outcomes. All the work on this issue has been either at the geographic level or at the hospital level, and you find very different things. At the geographic level, we all know that variation is not very well correlated with outcomes. When you start to drill down at the hospital level, we do find in a number of studies that higher spending hospitals have better outcomes. We have some work now that's under review which shows that within the same hospital, higher spending doctors have better outcomes, lower 30-day mortality among their patients than lower spending doctors. So it could be that the association that we find here is because there's actually improved outcomes, and we wouldn't want to obviously call that a bad thing. The alternative possibility is that higher spending by a physician only reassures patients or judges or juries or attorneys that more was done or that an exhaustive workup was done. And in which case, that's a costly way to convince patients in the system that appropriate care was provided. But nonetheless, I wouldn't say that this is conclusive evidence of that defensive medicine, quote unquote, works, but it's the first evidence that we have. It points in that direction, and I think that it opens up avenues for better analysis than this. I'll stop there.
Thank you very much, Bapu. Our third speaker is Mike Morrissey, health economist, professor and chair of the Department of Health Policy and Management at Texas A&M's University School of Public Health, with his research interests focused on employer-sponsored health insurance and the effects of legislation and regulation in health and healthcare. The latter aspects, including the effects of regulation and legislation focusing on medical malpractice and motor vehicle safety. Mike's an adjunct scholar at AEI, fellow of the Employee Benefits Research Institute. Many of you remember before joining Texas A&M in 2014, he was a professor of health economics at the University of Alabama at Birmingham and director of the Lister Hill Center for Health Policy. Mike's written on medical malpractice in the past. He's going to be more of a discussant today, giving his reflections on the two presentations and his broader thoughts on this issue of medical liability.
Thank you, Tom. Delighted to be here. The last time most of us in this room thought about medical malpractice, I suspect, was in the waning days of the Bush administration, when there was some thought that federal reform efforts may be underway. So I thought I'd start by saying, sort of, what did we think we knew then? Well, what we thought we knew was that damage caps reduced malpractice premiums, maybe by about 4% for each $100,000 of tighter cap on non-economic damages. Other tort reforms probably did little or nothing, depending on which study you looked at. Damage caps had little or no effect on physician location decisions. Certainly when you started to control for almost anything, the apparent effects started to go away. There was some evidence that damage caps did reduce healthcare utilization and maybe spending on heart disease and on C-sections and on neonatal care. But it was not at all clear that those results were generalizable to other areas of medical care. There was little evidence that damage caps reduced healthcare spending when you looked at prices of healthcare services, for example. And there was little evidence that damage caps reduced employer-sponsored health insurance premiums. Actually, that's not quite fair. My stuff said that. Professor Daphne at Northwestern found an effect of 1 to maybe 1.1% reductions. So from that, the sort of the takeaway was when you started looking at the defensive medicine issue, you had to reach sort of one of, or maybe two conclusions. One was that defensive medicine didn't exist in any meaningful extent, and a number of economists have certainly bought into that. And secondly, or alternatively, that defensive medicine was little affected by tort reforms. And indeed, Patricia Danzin at the time was clear in making the point that there was more than the malpractice premium that went on when one, as a physician, thought about how to treat patients. Now, as Anupam discuss at the end, there are lots of physician views and indeed lots of physician surveys at the time of the last discussions of all of these reforms, where physicians sort of stated quite bluntly that they did lots and lots of defensive medicine activities. The trouble is, it's not really convincing that physicians are indeed generally smart people are able to mentally disentangle what's going on.
I second that.
Which part, the generally? or
Jenna,
the-
the Jenna part.
So a physician sort of decides to refer to a specialist because of the fear of malpractice or because it's good practice. It seems to me that what's going on sort of behind the screen in the intellectual and emotional areas of the brain are things, the nature of the training as to what constitutes good practice. And the decision relies on their own patient base. And from that perspective, it's all sort of wound up in sort of what they were trained and maybe what they've read subsequently, although what I've learned today is some specialists, maybe not. But also the sort of the nature of their own patient base, which is tied up with the economic and legal settings in which they practice. And from all of that, then the inference is maybe the defensive medicine is little affected because there's so many other things going on. And indeed, it isn't clear that necessarily it's the malpractice issue that led one to make the decisions they made. And what that suggests is even if malpractice reform works, it isn't clear that the effects on patient care would show up quickly, and then indeed they may be slow to evolve. Having said that, what went on with tort reform was essentially a trade-off. I mean, the argument was that if Coase was right, it doesn't matter to whom you assign liability because in a costless world they simply contract and work it out. But in a world where there is substantial asymmetric information, you want to assign liability to the group that is best able to sort of have that knowledge and deal with it. And so liability gets assigned to physicians. Well, what happened with tort reform, and particularly with damage caps, is we've sort of moved the onus of at least some of that liability away from physicians and other providers, and set it on the shoulders of consumers. The issue, though, is sort of what's the trade-off? That as a consumer, what do I get as a result of accepting this greater liability? And certainly the evidence that we have circa the end of the Bush administration is I didn't get a whole lot out of this. There's not much evidence that my health insurance premiums changed. There's not much evidence that prices of health services changed. All I know is it's harder for me to sue and to find an attorney willing to do it. So that's what we knew at the end of the Bush administration. So what's new? Well, we've had several more years of experience with relative calm in the malpractice world, and so we have more observations. But that's not necessarily helpful to the extent that not much is going on. But we have more observations, and certainly we have general trends now of malpractice premiums declining, but declining in states with and without caps, as David has pointed out, but clearly more aggressively in those with new caps. So malpractice premiums have declined, and we know that with greater certainty now. We also know a lot more about sort of the nature of why. So it's in some sense, the patterns that sort of and pathways that underlie us. What we understand from much of David's work now is that there are fewer claims, many fewer smaller claims, and higher payouts per claim, again, driven by the lack of those fewer claims. So consumers with small injuries end up being harmed. And that suggests that we need to think more aggressively about alternative mechanisms for resolution in those small claims, as David pointed out as one of the policy issues worth discussing. Does any of this, the new learning, do we know any more about whether or not physicians have changed the nature of the healthcare spending? Is there evidence that indeed, with the new learning, that we're saving more money? Well, no. The concern with what David has pointed out is exactly the opposite. In states that have enacted damage caps, what we find is spending on the Part B side, where we have all those examples of how defensive medicine was supposed to work, that spending, at least in a tentative sense, because he's not done it, have gone up, which suggests as consumers we're even worse off than we thought we were back 6-8 years ago. What we've also learned is that we have a much better understanding now of sort of the physician's decision-making process, as Anupam has sort of laid out very well. As economists pointed out for a long time, malpractice premiums are really pretty small potatoes. And indeed, the kinds of commitments that physicians have to make to malpractice cases are rather substantial. So we understand now much better sort of the nature of the process. And we understand from that work on spending that indeed there is some evidence that if as a physician I spend more, I'm less likely to get sued in the future. We don't know, and hopefully the next step in all of that analysis is to say, so what happens when I'm in a state that has enacted some tort reforms? What does that do to these sorts of physicians, high risk and low risk, and do they change behaviors? That leaves us with some conundrums here. One of the conundrums is we thought we were going to save money, and we may be actually spending more. Physicians are certainly, nuanced at worrying about the nature of the care they provide and how to provide those services. So what does all this say on the policy sides? I think it says that damage caps were a bad idea, and we need to sort of stop doing that. We need to look at other sorts of reform issues if we're concerned about the liability issue. We certainly have to worry about the small claimants issues, as has been pointed out. Three of the things actually that were being discussed at the end of the Bush administration were sort of alternative approaches. There was the disclose and offer approach, where as a provider you would indicate that I screwed up and I'm sorry and here's a settlement, can you sign these forms? And 35 states have enacted some sort of protection to providers that limits that apology in the courts. Mixed evidence of whether it actually reduces claims. And there seems to me there's an economic question, certainly in the presence of caps. Since it doesn't pay for a small claimant to sue anyway, why should I settle? Clearly, we need to think more about the disclose and offer and whether or not what that has to offer. There have been folks who have suggested health courts, alternative mechanisms where you have an experienced judge and team who can sort of winnow through whether or not it's a legitimate claim or not and what kind of settlements. And then, of course, being trained at the University of Washington in the old property rights days, I too have to talk about the contracting issue and suggest that maybe one of the proposals back then that needs to be considered further is enterprise liability. So I'll leave it to there, but I look forward to the discussion of policy options.
Thank you very much, Mike. We'll go to questions from our studio audience in just a moment. You were mentioning transfer of liability. It brought back a recollection from my days as a young attorney in private practice. There's another way to transfer liability. You could transfer it from medical malpractice liability to legal liability. I was a plaintiff's attorney and nearly missed the statute of limitations, in which case the client could have recovered in a different manner if it wasn't rescued. But our policy limits weren't quite as large. We ended up winning the underlying case. Let me just bring up to the panel, though, because what Mike raised, let me just ask this basic question. how do we distinguish between defensive medicine and, for want of a better term, habitual medicine? That maybe they're just patterns that the doctor is used to doing for a multitude of reasons, and you can call it defensive medicine, but maybe it's not really directly defensive, but it's something else.
I think that's extraordinarily difficult to do. I mean, that's why you need to look at what doctors do and not what they say. I mean, the example that comes to mind when you raise this question is if you had a young woman who with a history of anxiety comes into the emergency department and she's been in there 5 times in the last month, let's say, with shortness of breath, palpitations, and now she's having chest pain. And you review her medications and it turns out she's on an oral contraceptive pill. And so in the back of your mind, you've got to think to yourself, does she have a clot in her lungs? Because these pills can lead to higher rates of pulmonary embolism. And do you then order a CT scan of the chest because you're worried about being sued? Or do you do it because you know that the likelihood is still maybe 1% because you have all this other information that tells you that this is not a pulmonary embolism? Do you get the CT scan or not? And I completely agree with what Mike said, is that I don't think that it's easy to distinguish in a survey, at least, why it is that doctors may or may not choose to get that CT scan. They may do it simply because it's costless to them to get the CT scan and there is only a downside. And I think that's why you have to actually look at what happens to rates of CT scan use among these kind of gray area populations when when laws change.
Yeah, I want to agree with that and add to it a little bit. My rule of thumb is everything runs on autopilot. That is, things tend to keep being done the same way before because it worked before, and so the assumption is we should continue doing it until there's some horrific outcome that causes us to revisit our priors. And sometimes doing it the same way is patient protective, right? It keeps you from missing things or outsmarting yourself by saying, oh, I know this is a patient that I can break the general rule on. That's why standardization can actually be incredibly beneficial. And so the challenge is figuring out when do you want to stick with the tried and true and when do you want to revisit. You know, there's evidence suggesting that lots of the studies that get published are not replicable, and so maybe we should be cautious before we leap to doing things differently. I think the last point, though, and it dovetails with Bapu's point, is physicians consistently respond that they engage in defensive medicine, but you know, the studies that look at their behavior after you enact tort reform suggest that tort reform doesn't seem to have a major impact. And so maybe they're misperceiving their liability risk. Maybe they have other reasons for doing the things that they do other than liability risk, right? They think that it's good medicine to do it. They think that it's better to be careful than to be sorry and for the patient to be sorry. They value certainty, and so does the patient. You want the patient to be happy with you and to be happy with their medical treatment. And so it's the same set of reasons why we overprescribe antibiotics, right? There are a whole bunch of reasons for doing it, and the costs are externalized and not directly visited upon often either the patient or the physician. And so why the heck not? I don't want to overstate the point, but you know, there's a whole constellation of reasons why physicians do what they do. But if we take away liability risk, we don't see much of a change. And so that maybe we should come up with something other than defensive medicine to call what's going on here.
We could call it wasteful medicine.
Well,
That would be
if
wrong.
you want to be mean, yes, you could.
All right, only on occasion. We're going to have some questions, and when you provide your verbal op-ed, just not only indicate who the author is, but also inflect your voice at the end to make it sound like a question, please. We'll start over there.
My name is Dana Connors. I'm from the Electronic Data Methods Forum at Academy Health. And I think this is an opportunity, or I guess my question is there an opportunity here in this most recent discussion for inserting, and now in the age of big data and all the information that we supposedly have, clinical decision support, so we can take the onus off of the provider and point towards, especially for outlier situations, right, in the gray area where we're working with a 1% chance of adverse effects, that we can point to clinical decision support and say, well, I used this algorithm and this is what it told me, and therefore...
What Watson told you.
Correct. Is this a place to use that opportunity and to also bring in the supposed big data that is now available to us? And how, if you have an idea, how would we do that?
So it's an interesting suggestion. It's part of the what I would view the larger constellation of we should have treatment guidelines and compliance as a safe harbor. And some of the states have actually experimented with that. Sometimes there's an argument over whether it can only be used as a shield as opposed to a sword, right? Because it turns out people who are keen on having them serve as a shield are suddenly unenthusiastic when noncompliance is basically proof of negligence per se. And so, you know, there have been some fights about that. I think that's so far been not a particularly productive malpractice remedy, partly because many physicians don't want to be told what to do. And so they're unenthusiastic about, here's a cookbook, as long as you follow it, you won't be sued. I think they prize their autonomy more highly than compliance with the cookbook would require. And the same actually goes for enterprise liability. Physicians, I think, recognize that if there's enterprise liability, somebody else is going to be their boss as a corporate organizational matter, and so they tend not to be as enthusiastic about that, even if they can externalize their liability risk by doing it. I guess the last point is there's an article, I think it was in JAMA, it's now probably 5 or 8 years ago, about a case where a physician tried to point to practice guidelines as a defense, and the plaintiff's lawyer had great fun pointing out how this was just a bunch of bean counters trying to keep their client from getting the health care that they actually needed. And in fact, it was not quite a conspiracy to do bad medicine, but the closest thing to it. So I think we need a high degree of faith in big data and practice guidelines for it to function in the way that you're suggesting. And I'm not sure we're there yet.
Let's go to Joel.
My name's Joel Zinberg. I'm a surgeon in New York City as well as a visiting scholar here at AEI. And one thing no one particularly touched on when trying to relate tort reform to defensive medicine is the sense among physicians that the tort system is a capricious system. There have been multiple studies indicating that the payouts, the number of suits, the number of payouts do not necessarily correlate with bad care or negligent care. You can have a bad outcome and not be sued. You can have what seems to you to be a perfect outcome, yet you end up as the subject of the suit. And it seems to me the threshold issue for most physicians is, do I get sued? Is it for it doesn't make much of a difference if it's $10 or $10 million. It's that psychic problem, which I think is far greater than the financial problem that most physicians fear. And that's, I think, what ends up motivating defensive medicine. But I did want to ask, now that I've made my pitch, the inflection's coming. So, Dr. Jen, I did want to ask you, I did see your study, and I did wonder, the way you did touch on a bit, is this defensive medicine, or is it good medicine when you spend more money? And were you able to look at the outcomes of those folks who spent more money? Did they have the patients have better outcomes than the folks who spent less money?
So I think it's probably a combination of both. It's hard to know what's the causal effect of spending. As I mentioned, we have some work now where we look at Medicare data, and so this are all Medicare beneficiaries in the U.S. who receive hospital care, and we show that within the same hospital and specialty, higher spending doctors have better outcomes in terms of 30-day mortality than lower spending doctors. And that is true even among what we call hospitalist physicians. These are physicians who only deliver hospital-based care. And the reason that's important is because they work shifts, and so they don't pick their patients. They are essentially quasi-randomized. Patients are essentially quasi-randomized to a given hospitalist physician during in a particular hospital, and so we think that it's almost random, and we find the same effect. That being said, I mentioned this work on cardiologists and what happens when they go away to meetings, and obviously in that work we're arguing that more interventional care is probably harmful. So I don't think that there's a clear relationship about physician-level spending and outcomes. My hunch is that in the Florida data that we analyzed, that we would find, we haven't done it yet, but we would find that outcomes are better. And it makes clinical sense. I mean, you order tests, you order procedures. Yes, there's risks of adverse effects associated with them. Yes, there's risks that you pursue bad pathways that you wouldn't have pursued if you didn't actually have that information. But there's also a lot of good information that comes from tests. And to start making conclusions about whether or not we're overutilizing care, underutilizing care based on whether Miami does better than Minneapolis is very misleading. What we need to know is whether Dr. Thomas in Good Samaritan Hospital, who is an internist in Miami, who spends more than Dr. Smith, has better outcomes. That's what we need to know, and my guess is that we'll see that they do.
I was tempted to, you made the distinction among physicians, to ask whether you looked at spending in Mass General, having recently heard some
There are no errors.
comments on that relative to the quality of care.
There are no errors at Mass General. That is a fact. No.
As long as we cleared that one up. Just stay down here for just a second.
Thank you. My name is Li Yang. I just wonder if you analyze or if you know any study about this kind of incidents. Do you compare the real record or just have a lawsuit or just where you get a record, and whether psychiatrist is considered as a physician, and whether the death under psychiatrist care is part of the defensive medicine, and whether the national origin of the patients or their last name or their first name sounds like somewhere Muslim or Middle East. Do they cause more torture, more harm, or more suicide? Any jailing or police killing, would they related to this kind of defensive medicine?
So I hear a few questions there. One is, what do we know about psychiatrists? And then two is, what do we maybe know about the types of patients who are more or less likely to sue? So psychiatry as a field is generally a lower risk specialty compared to others, primarily because the clinical decisions that they make, I think, are more removed than that, let's say, of a neurosurgeon. So in that sense, being a psychiatrist is relatively good from the malpractice perspective. From the issue of what types of patients sue, there's actually not a lot of great data on that. There's a lot of data on it. I wouldn't say it's great, but what I would say is that almost 90% of the data does suggest that there is no real relationship between things that people have been concerned about, like Medicaid status or socioeconomic status, and risk of suits. I mean, that's something that physicians talk about. It doesn't really bear out in the data.
Just a quick follow-up, if on the psychiatric point, but also on the broader set of issues, if you think about this from the perspective of a plaintiff's lawyer for a moment and ask yourself, what kinds of cases will plaintiff's lawyers be willing to take on contingency? It's going to be cases where liability is pretty straightforward and damages are sizable. And when you sort of get over a critical threshold of damages, they're interested in talking, but short of that, it's going to be very expensive, even if you don't have tort reform, but especially if you have tort reform, for them to take the case, right? So the challenge and the way to think about this is, what are the kinds of cases where either liability is going to be much harder to prove, or sometimes impossible to prove, or damages are relatively modest compared to other kinds of cases. And psychiatry, it seems to me, is likely to, liability is going to be more of a challenge than leaving a sponge inside a patient or operating on the wrong side, none of which either happen at Mass General, and damages. They'll notice that immediately. Jeez, you're not helping here, Tom. And damages, so economic damages, I think, at least it's an interesting question. I don't know any data on this, but I would at least wonder about the cohort of people who are going to fall into plausible claimants, how large their lost earnings would be. Okay, so that would be the way to think about it, not just medical expenses, but also lost earnings. So if you think about it from the perspective of a plaintiff's lawyer, you can get some useful traction on the kinds of specialties where people are more or less likely to be sued as well.
Question back there.
Dean Clancy, Adams Old, LLC. This is a Beltway policy question arising out of this very helpful discussion. Tom Miller you followed the CBO scoring of medical malpractice reform, federal malpractice reform over the decades. And one of the panelists said, well, what we now know is damage caps were not a good idea. And I assume CBO's scoring of federal proposals assumes that damage caps save a lot of money for federal programs. Do you think that the information in this panel will it change what CBO says? And if
They always
so,
change
when?
the score right after our sessions end. But probably not. There's, the process, and Joe Antos, my colleague, could certainly speak to that. But I know from our lips to somewhere else than their ears is the general rule of thumb. Let's switch over on that to this. We'll get on the other side of the room. Down there, please.
Thank you. Gerald Chandler of iTech Consultants. Could you expand your discussion of defensive medicine to fear of federal lawsuits for excessive practice where the Justice Department comes after you for spending federal money that you shouldn't have spent in Medicare and so on?
It's an interesting question. I mean, fraud control is obviously trying to address that, but it apparently is not nearly a big enough threat, judging by the frequency of fraud prosecutions in particular parts of the country, especially, right? So, Florida, which has come up already, is not quite it is ground zero for healthcare fraud, right? They're immensely creative at extracting money. And it's everybody from, fly-by-night fraudsters to quite respectable members of the healing professions, which is somewhat disconcerting. The difficulty is caps wouldn't have anything to do with that, right? And it's going to end up in the Medicare spending numbers as well as non-Medicare spending, but we don't have an easy way of capturing how much of it is attributable to that. So I guess I would expect fraud prosecution, especially if it's a reasonably constant presence, to not wax and wane based on whether you've enacted tort reform or not. Okay.
So we've got just a couple more minutes. I saw a few hands back at this table.
Ella Toombs, dermatologist. Over the past 15 years, training of medical students and residents has changed tremendously. So that previously, the patient really wasn't thought so much as being a human being. It was the kidney, the lung, the whatever. But there's a lot more emphasis now on the more holistic, humanistic approach to patient care. So my first question is, it may be too late to get that too early to get that data, because those physicians may not have been out in practice long enough to really know. But the question is, are there plans to look at that and see what difference in medical training has made in actual malpractice rates? Also, the Affordable Care Act has certain, I don't want to call them restrictions, well, maybe I'll use the term provisions, but at any rate, that affect hospitals, patient readmission and all that kind of stuff, that affect hospitals as well as that affect physicians, particularly primary care physicians, in reaching certain goals, et cetera. So are there plans to also incorporate or at least look at that data comparatively in order to see whether ultimately that makes a difference, whether they make
So maybe I'll take a stab at the first question. So there is, we have done some work that none of it looks at the approach of humanism versus disease-based thinking of patients, but just thinking about how medical training has changed now versus, let's say, 15 years ago. Actually, I think the biggest change in medical training isn't actually the approach to the patient, but is the kind of hours and what's expected of doctors during residency. So now when you train as a resident, you work a maximum of 80 hours per week. It used to be that you would work without a maximum. So the older doctors were working 100, 120 hours. I don't know how many hours you work during residency, but 100 hours would not be atypical. And the concern has been that with this change in what we call duty hours, that doctors aren't as well trained for independent practice as they used to be, whatever that may mean. And we've looked at some data, again, also from Florida, where we have the information on these particular doctors. We know when they graduated from medical school, residency, what they did residency in. And we see no difference in the last 10 years in the quality of doctors completing residency. So if you look at doctors who are in their first year out after residency, who are now new independent practitioners, or what we call attending physicians, these doctors have the same mortality outcomes as they did 10 years ago once you kind of control for overall changes in outcomes in the last decade. The last point is there are clear relationships between physician experience and patient perceptions of the quality of their doctor, as well as how well doctors adhere to outcomes. So there are some studies that suggest that patients prefer more senior clinicians. If you look at the outcome measures that are out there, it turns out there's very little data on the role of physician experience and outcomes outside of surgery. So within surgery, there's a sweet spot for when you should be operating as a doctor. But for all the other things that are kind of general medicine, there's not a lot of data. We have some data that suggests that senior clinicians have worse outcomes for things like pneumonia, heart attacks, heart failure, but that's about it.
Yeah, just quickly, the difficulty with studying malpractice along those measures is you, first of all, need identified data rather than de-identified data, and you need quite recent data, and it takes a while for malpractice claims to be brought, as we've already heard. And so, you're always going to be at least 5 years behind, and probably more, in being able to get data, if you can get data, to track that.
All right, we're just about out. Do we have any further questions? With that, data may or may not make a difference in this strange type of policy debate. You've just heard from some of the top experts in the field. Now, I want to point out that no one was, as far as we can tell, harmed medically during the course of this event, but it's a free country, and if you want to sue over it, I could change the license from inactive to active status in the bar, but you better be a particularly appealing plaintiff with a good income stream. Otherwise, I'm not taking it on. Thank you very much.